Okay. Well, thanks, Louise, for inviting me. I'm delighted to be back at a DSN annual meeting. DSN's really important to me and does incredible work. And I'm really delighted to hear about the link-ups with NHS Practitioner Health, which is fantastic that two such fantastic organisations are coming together to work together. I'm Richard Duggins. I'm a consultant psychiatrist and psychotherapist, and I work up in Newcastle. Um, Louise introduced me as a clinical lead with NHS Practitioner Health, and I was very proud to be a clinical lead with NHS Practitioner Health. There's been some changes in how the lead structure works recently, so I'm still working with NHS Practitioner Health and really enjoying that, but I'm not a clinical lead at the moment. I've had an unusual consultant career in the fact that for the last 16 years now, I spent most of my clinical work looking after NHS staff with burnout or other psychological health conditions, and I continue to be able to do that, which has been a wonderful experience. I really enjoy working with staff, and one of the reasons I really enjoy working with staff is because staff do so well in their recoveries. It may take some time, it may take some persistence, but we usually get there in the end, and that is great. So I'm going to, as Louise said, I'm going to talk about how therapy can help. And quite a lot of this is from my Wounded Healer presentation that Louise came to. I've added to it a little bit and took some other bits away to kind of make it more general about how therapy can help. So what I'm going to do, I'm going to start with just almost because I can't do a presentation without mentioning it, I'm going to talk about Laura Dunn's model of burnout. I'm then going to talk about, so I'm a psychoanalytic psychotherapist, but I'm also an IPT therapist, an interpersonal therapist. And the bulk of the presentation today is going to be about what IPT techniques we tend to use as IPT therapists in therapy, and kind of explaining a bit what we do in an IPT therapy and how that may help people kind of recover and stay well, and just kind of sharing those with you. And it seemed at Wounded Healer that was appreciated, that kind of inside view of what we do in therapy. And then I'm going to end a little bit by saying, in my opinion, how you should go about, if you're in that position, choosing a therapy or a therapist. So I'm going to give some thoughts on that. Okay, I'm going to start just by saying this slide, which if anyone's ever seen me present before, will have seen me talk about before. I was introduced to this from Claire Gerarda, NHS Practitioner Health, and it's Laura Dunn, who is a psychiatrist in California, and she talks about what determines whether we feel burnt out or resilient. And she says that it's not about the individual. It's not whether we're burnt out, resilient isn't a personal quality. It's about the balance of what's going on around us. It's about in the system. And the reason I'm mentioning this is I think there's a danger if I just talk about therapy for us, that therapy is something individuals do. But I think we have to separate that from what might cause us to become distressed or burnt out or unwell in the first place. And I sincerely believe and have been taught for my 16 years that what causes us to burn out or become unwell has very little to do with us. It's more to do with what's going on around us at the time. But once we become burnt out or unwell, individual therapy can help. So there's a bit of a I just want to clarify that I think what makes us unwell is usually something going on in the system around us, but that doesn't mean that we can't start to recover by doing some individual or group therapy. So just to go through Laura's idea about burnout and resilience, which I really agree with, is she says that we're more likely to feel burnt out if there's lots of negative inputs, and we're less likely to feel burnt out if there's more positive inputs. So very briefly, the negative inputs are what we might expect them to be: kind of stress at work, so the length of hours worked and the intensity of that work. Internal conflict is how we feel about work, which is often determined by, for example, the leadership at work, the teamwork at work, perhaps how the media is portraying our work, perhaps if we've got any complaints or things like that going on. So how do we feel about work? And the last thing is time and energy demands at home. So obviously time and energy demands at work add to time and energy demands at home, and they can't be considered separate. So if you've got a lot going on outside work, obviously it affects us. And they balance with positive inputs, and Laura Dunn talks about these as psychosocial support. So really, is this: has somebody got your back at work, and has somebody got your back at home? I think I saw Ross nicely have Louise's back by going to get her a glass of water earlier. So that kind of thing, that's really important. Other positive inputs are: do we have time and the energy to do social and healthy activities? As I'll talk later on, these are different for different people. There isn't one rule that everyone should go running or cycling or join a choir, but they are examples of things that will help some people. Mindfulness might be within this as well, or crafting, or various things, but they're individual to the person, but they really do help. Mentorship is, if we're at work, do we have some good supervision at work, either by peers or by supervisors? That really helps, having somewhere to talk through those difficult decisions, which is also really important why this coaching offer is there, because that really helps. And then the last thing Laura Dunn says is, in the balance of these positive inputs that make us feel less burnt out, is intellectual stimulation. Is there something going on in the week that you really enjoy? This might be a particular clinic, it might be, if you're a surgeon, a particular list that you do, it might be something like teaching, management, anything like that. And if you can't have that at work, can you have it outside work? So this might be a community activity, but something that we can look forward to each week that intellectually stimulates us is really important. And it's this balance, and it's when things get out of balance, Laura Dunn will argue that we're more vulnerable to becoming burnt out, and possibly more vulnerable to becoming unwell. And you can see how COVID tipped the scales in an awful way, that those negative inputs went up massively, but the ability to do those positive inputs went down massively. So you can see why that was such a difficult time. And of course, if the negative inputs are high and you've got lots of time and energy demands and lots of stress, you may not have the energy and the time to do the positive inputs. So that can also tip things. Okay. So moving on now, so there will be time for questions at the end. Moving on now is talking about interpersonal therapy. So this is a particular sort of therapy that I'm a therapist in. And the two other names on there, Dr. Liz Robinson and Catherine Edmonds, which are two other IPT trainers that I work with. And we sat down for the Wounded Healer conference thinking, could we share something about what we do in IPT that might be helpful for people to hear, and kind of be open about that. So that's what we decided to do, and that's what you're going to hear in these next set of slides. Okay. So just to say a little bit about IPT, there's a picture of a book there by Ros Law, who's a British IPT therapist, called Defeating Depression. It's a really accessible book written for the general reader. So if this does interest you, there's that would be the book I'd go to. IPT is the second most researched psychotherapy in the world. CBT obviously being the top by quite a way away. It's a nice approved psychotherapy for people with a diagnosis of depression, with people with a diagnosis of bipolar disorder, or with a diagnosis of bulimia. and there's emerging evidence base in post-traumatic stress disorder. So we use it in our trust for all of those. And there's a brief form of IPT called interpersonal counselling, which is used for distress. So this is used in briefer form. Normal IPT is about 16 sessions, 16 meetings with a therapist. IPT is about IPC, this interpersonal counselling, is usually about 3 to 6 sessions with a therapist. And what I'm going to be talking about mainly is interpersonal counselling here. So what do we help people think about when they come to us with experiences of distress? Okay. So in IPT and IPC, there's certain principles and techniques that we use. The therapy is split up into the first few sessions will be what we call an initial phase. The next few sessions will be what we call a middle phase, where we do the bulk of the work of therapy. And then there's an ending phase for the last few sessions. So it's split into 3 phases as you go along. It's what we'd see it as non-stigmatizing. So it sees the distress as the problem, and it doesn't see what's going on as our fault. So you would work with IPT and IPC to say, you're experiencing this stress. How can we work together to lessen it? So you're working together to manage that distress, really. So and one of the things we do in IPT is we say, what is it that's possibly caused this distress? What's changed? What is the focus of the work together? So are you feeling this distress because there's been a change in your life? Because you've got a dispute with someone, you've got a disagreement with someone, because you're grieving, because you've had a loss, or because you're lonely. And IPT will encourage us to think about whether distress is linked to one of those focal areas. And the techniques we use in IPT are staying with emotions. So one of the major principles of IPT is that one of the things that's really important in therapy is staying with and feeling our emotions and working through those emotions, not avoiding them. We use something called communication analysis, which is looking in detail how we talk to people, and the good things and the bad things that are in those conversations. We use in IPT, we use role plays, which is really just practicing what you might say to people. And we use decision analysis, which is how we make decisions, because often how we make decisions isn't particularly well thought out. So I'll say more about all these things, but that's a kind of introduction. Okay, so the first bit of IPT, the first few sessions, is called the initial phase. And what we encourage people to do, and actually you don't need to be seeing a therapist to do this, you could do it yourself, is one of the things we encourage people to do is, what are your symptoms of distress? So when you're distressed, or what are your key symptoms? How do you know you're distressed? So that might be that you feel more irritable, or you feel more withdrawn, or you can't sleep. It's different for different people. But what are your key symptoms? And therefore it makes it easier for you to spot when you are distressed and you're experiencing distress. And it will also make it easier to spot when those symptoms have gone away. And then the other thing we ask people to do in the initial phase is we say, well, if you're going for a period of your life where you're feeling distressed, actually you won't feel distressed all the time. There will be some times in the week when you'll feel more distressed, and there'll be other times in the week when you'll feel slightly less distressed. So what we say is, can you identify, almost by keeping a diary, really, what's going on in your life when you feel more distressed or less distressed? So, for example, if you're generally feeling distressed, but you think, I felt even more distressed on Tuesday morning, what was going on in your life on Tuesday morning that made you feel more distressed? Was it that something had happened with somebody, or something particular something particular gone on, and I'll come to what those could be. And similarly, if on Thursday afternoon you were feeling slightly less distressed, what went on Thursday afternoon to make you feel slightly less distressed? So was it that you met up with somebody, or you did something that you enjoy doing? And what you kind of encourage people to do from that kind of familiarity of how their symptoms alter through the week is, in a way, trying to do less of those things that make you feel more distressed, more of those things that make you feel less distressed. It sounds very simple, and it is very simple, but once people get the hang of it, it really works. And what people tend to report to IPT therapists is, I used to think my kind of distress or low mood just came out of the blue, but through doing IPT, I recognized that I have got some control over it. And that can be really empowering for people. But it takes some time to get a hang of. The other thing we do in this initial phase is ask quite sensible questions, which is, what does your self-care look like? Do you need to do less of some things? So if you're feeling distressed and things are difficult, do you need to drop some things, or delegate some things to other people, get some help with things? Do you need to do more of other things? So as you're becoming more distressed and tired, have you perhaps dropped some of those things that were good for you? And do you need to start doing those again? There was a study of New York cops who were burning out, and this study of New York cops developed the idea of Eustace syndrome, and that was because the New York cops said, before I burnt out, there was all these things I used to do. So are there some things that you used to do that would be useful to start doing again? And then the last thing is, who can help? Often when we're feeling distressed, we don't think who's around who can help, who is there, who we can reach out to, who can help. Yeah, we try, and doctors tend to be particularly bad at this. We try and solve our problems ourselves rather than reaching out for other people to help. The next thing we encourage people to look at in the initial phase is the question of, who are your radiators and drains? So who in your life radiates energy, increases your energy, makes you less likely to feel distressed, and who drains your energy, makes you more likely to feel distressed. We'll then move on to, in the initial phase, a really important bit, which is saying, well, if you're going through this period in your life of distress, what's caused it? Is it because there's been a change in your life? Is it because there's been a dispute with someone? Is it because you've suffered a loss? Or is it because you're lonely? And then once we can identify what's caused the distress, say it's a change, can we set some goals in how to address that change? But we always say in IPT, whatever caused it, one of the goals of the therapy is going to be improving your social network, your support network, and another one's going to be getting even better at getting your needs met in your relationships. Okay, this is one thing that we stress in the initial phase, that we want people often to start doing some more things that are good for them, but it's not just anything. It's to do things that are pleasurable. Yeah. So it's not just any activity. It's taking up things that they used to previously enjoy, or they think they will enjoy, and that's different for different people. And then the other thing we look at in this initial phase is the idea of support networks. And one of the things that IPT says is actually support isn't just one thing, and not many of us get all our support from one people. We get them from a network around us. So one of the ways we remember this in IPT is head, shoulders, knees, and toes. So who is around for us, or could be around for us, for our head, to help us get our head together and think through problems? Who's a good problem solver around for us? Who's around for us, which we remember by knees? Who's around for us that we can have a knees up with, to be fun around? Who's around for us that are shoulders, to be a shoulder for cry on, can offer that emotional support? And toes, who's there that can give us a gentle kick to the backside when we need it? Who's our cheerleader? Who gives that emotional support? And what we encourage people to do in IPT is to think around who's around for them, and are there any particular areas there of support that they might need to work on and develop kind of new people, or reach out to new people to develop those? Or are there people who could help them with those areas of support that they're not reaching out to? So the idea of support being a network and of different things can be really important. So we do a lot of work in this initial phase, but then after that we move into the middle phase. And what you tend to have done what you've always done in IPT or IPC is said, well, what has caused this period of distress? And one of the things that can cause periods of distress for us are changes. And change, and what I mean by changes are life changes. So this could be starting a new job. It could be a relationship, a romantic relationship starting or ending. It could be developing a physical or psychological health problem. It could be retirement. It could be having children. It could be an elderly parent getting unwell. There's all sorts of changes in life, and when we go through changes, we become vulnerable for distress. So if our distress is linked to a change, what we'll try and encourage people to do in IPT and IPC is to we'll try and help them process their feelings linked to the change. So to speak about how that change has made them feel, but also in a practical way help them deal and adapt with the change. So we'll explore the nature of the change, the feelings about the change, how to make best of the situation, and also, because it's IPT, who's around in your network who can help you with this change. So when we're doing change as a focal area, one of the things that my colleague Liz often encourages people to do is think of their life as a book with chapters. So chapter 1 is, what was life like before the change that happened? What do you miss? But was there anything in this chapter that was difficult? Sometimes when we're forced into a change, we can idealize the state before the change, but sometimes it's not. It's when you look at it realistically, it wasn't perfect. Chapter 2 is, what was life like when the change happened? How did it feel? What was your support like? And obviously, if a change is forced upon us or is very sudden and we haven't got much support around, that makes that change more difficult. And chapter 3 is, life has changed. So how can we make the best of it where we are now, and how can we move forward? Who's around who can help you with this, and how does it feel? So I'm thinking, reading that one of the ideas might be, for example, if you're in a change and who can help you with that, that's where things like coaching might come in, or something like that as well. Yeah. So, but always encouraging people to stay with the idea of how does it feel, because those feelings are important. Now, our distress might not be linked to a change in life. It might be linked to something else. And one of those other things that it might be linked to is a dispute. So this is, have we got a difficult relationship that's causing our distress with someone else? So this could be a romantic partner, could be a child, could be a parent, it could be a boss at work, or it could be a co-worker. And if there's a dispute leading to that, then we'll focus upon that dispute. And the aims of this kind of work is understanding what the conflict is about and what we can do to improve the situation. And we'll tend to ask questions about, if this is, for example, a difficult relationship with a co-worker, what do you expect and want from that co-worker? What do you think they expect and want from you? And often you can get those different expectations, and they can lead to the conflict. Are there alternative ways you can communicate with each other? Has your communication been good? Do we need to look at communication? Do we need to look in detail, perhaps what one of the difficult communication has been been like, and break that down. Have a look almost sentence by sentence about what happened, and then think together about whether we could, if that opportunity comes to have that again, as often repeated patterns happen in relationships, whether you do something different. There's a phrase in IPT which is strike while the iron's cold. So often when the emotional temperature in a conversation is high, that's maybe not the time to deal with things in that conversation. It's to kind of let it settle down, but then go back to that conversation when things have settled down, which is striking while the iron's cold. And then once again, who can help? Who can perhaps help you with this dispute? Who can support a better form of communication or relationship with you? This is a bit more. I've kind of said all of these things, but in disputes, we're thinking, do the two of you have the same expectations of each other? Are you communicating what you need, and how might this be viewed by the other? Yeah. So, sometimes in relationships, we very much want our romantic partner to have a sense of what we need and want, but sometimes actually, despite what we hope for, we might need to be very clear with them and tell them what we hope for and want, so they can understand it. Can you understand the other person's perspective? What are the options available, and how would they feel? So, if it is a dispute at work, what options are there to resolve that dispute, including, of course, looking for another job. But how would that feel? And is there a compromise? Is there a middle ground? Can you kind of, rather than going for a win, can you go for a draw? So we've got changes can cause distress, disputes can cause distress. The other thing that's common in life that causes distress is grief. So IPT can help with grief, and if this is quite naturally is to help somebody mourn their loss and help them connect with others. And what we're doing is really here helping someone move to healthy mourning if they're perhaps struggling with it, which is often getting sense with their feelings around the loss, and exploring the relationship. And also thinking, once again, because it's IPT, who's around in your network who can help. So this is Catherine, my colleague, who often, when she's doing this grief work, does this kind of conversation with people. So she'll say when someone dies, it can be easy only to remember the good things or the bad things, and she'll encourage people to think of 3 stones that make up parts of the relationship with someone who's died, and she'll say they can't be separated because they all make up the whole person. So she'll encourage somebody to think about a rough stone. So what are the difficult memories when you think about the person? And that might be, for example, seeing them ill in hospital. And then she'll think about a smooth pebble. What are the everyday memories when you think about with this person? And the example here Catherine's written is he wore blue slippers and loved watching the rugby. And then the gemstones. What are the precious memories we think about with this person? And the example Catherine's put here is we went on a holiday to Spain in their final few years. So kind of encouraging this kind of whole conversation within the grief to move somebody towards a normal grief, really, which is great, which will obviously take time, and all you want to do really in the 3 to 6 sessions or even the 16 sessions is just to start that off. Okay. The last thing that can cause distress is loneliness, and we might see this typically in doctors, for example, if they move away to a new area to get a job, or there's a change and their key supports move away to get a job. I've seen this, for example, when key supports have gone and got jobs over in Australia and New Zealand, and what was a good support network can suddenly feel quite lonely. And what we're doing with people who are feeling lonely is helping people build confidence in forming new relationships and helping reduce their isolation. So we might look at what worked and didn't work where in past relationships, whether there's any repetitive patterns, expectations, or communication difficulties that might lead you to be lonely, what can change and who can help. And often drawing on your success previously of making good relationships, and then kind of working on that again. Okay, so the idea in IPT is there tends to be 4 reasons why people might feel distress: change, dispute, grief, or loneliness. Okay. Within all of those, we tend to use some key techniques within IPT, and a key one is staying with emotions. So we're more in danger to feel distress for a length of time, or to feel other feelings related to distress. Actually, if we put our emotions under the carpet and we ignore them, we're more likely to be able to move on if we stay with our feelings, however painful that will be. We look at communication analysis. So if somebody's had a difficult conversation with somebody, we encourage them to look in detail with us at that conversation. What went well, what didn't go well. If somebody's had a good conversation with people, we'll say the same thing. What went well? So what techniques can you use that went well in that conversation in your other conversations? Communication being a key to managing our distress. We'll do role plays. So we'll say, for example, if you're repeatedly having difficult conversations with someone in your life, well, let's have a go. Let's have a go at, I'll play them, or you play them and I'll play you. Let's have a go at doing a different kind of conversation. And then what do we make of that? And the last thing is decision analysis. This is how we make decisions. And IPT is very much around the fact that we make our best decisions if we use both our head and our heart. So we like any good decision analysis, you will use blue sky thinking to think of a range of options. But then how do you choose between them? And we'll say in IPT, use your head. What are the pros and cons of this? But your heart, what's your gut telling you? Because your gut tells you something really important. And then also thinking, if you're making a decision, how's that going to affect your future relationships? Because they're key to staying well. So in the last bit of IPT is we spend a few sessions on the ending. One of the key things there is the staying healthy plan. I don't do this, but Catherine does it, and it's quite a nice way of illustrating it. She'll talk about thinking of us as a car. What do we? So this like topping up with petrol. What do we do with keeping ourselves topped up? What do we do with keeping ourselves where we're less likely to feel distressed? She'll talk about avoiding hazards. So what are the particular hazards in our life? Those kind of bumpy roads that we need to be careful about. What do we need to avoid to stay healthy? Having a regular service, keeping it. If once we know what our signs of distress are we watching out for them? And how will we monitor this? And certainly some of the people I work with a diagnosis of bipolar disorder will continue for quite a long time to keep a diary where they're monitoring their kind of symptoms and signs of distress. And then they get very good at nipping things in the bud, of doing things if things start to go off. And then going to the garage. So what's your plan if you do notice early warning signs? What will you do? Who are you going to ask for more help? What are you going to put in place? So you're not kind of scrambling about if you're starting to have early warning signs. You know exactly what you're going to do. That's the ending. Okay. So that's the bit around IPT. I hope it's an insight into what we do in IPT, but also might give you an idea of some of the things that you might be able to do yourself if you wish to do, because I think many of those things you can do without a therapist. And Rosa's book is very good at that if you want to go to that book. It's got a lot more about all of those things, including all the techniques. And I thought I'd end, there's just a few slides here about, in my humble or honest opinion, how I would choose a therapy and a therapist. So how to choose a therapy is I think an important thing to say is, because we are doctors, we do have the option, if we're unwell, to go to an organisation that will give us great advice of this. So you could go to NHS Practitioner Health, and you don't need to do all this yourself, because you'll have people to talk to who can give advice on therapies and also on therapists. And of course, if appropriate, NHS Practitioner Health can fund brief therapies. And then the other organisation that's very good is Frontline 19, a charity for frontline staff, which is anyone who's patient facing. But if you're making the choice yourself, the way I would do it is thinking, well, what I'm struggling with, if you know what you're struggling with, is there an evidence base for that? So if it's anxiety, the evidence base for anxiety is mainly CBT. So I'd be thinking, okay, I'll do a CBT therapy. If it's depression, then the evidence base for depression is mainly CBT and IPT. So I'd be very tempted to go down one of those as a first line, if that was what I was looking for. If it's PTSD, I'd be looking at EMDR or trauma-focused CBT. So if there's an evidence base, follow that evidence base. It's there for a good reason. Yeah, just because we're doctors doesn't mean nice guidelines don't apply to us, because of course they do. But if it's less clear, then one of the things that I'm interested in is whether we get a sense of what's our kind of go-to attachment style. So stay with me a little bit with this, but this is what kind of person are we tend to be in our relationships. And when I work with doctors, I mean, because we're all different, but I tend to see two big attachment styles with doctors. One is the kind of dismissive attachment style, which a dismissive attachment style is where you kind of keep your feelings to yourself. You don't particularly show them, and you kind of keep the emotional tone of relationships quite low. So you just kind of get on with things. Quite useful for a doctor, to be honest. With our distressing work, to be able to keep those feelings low and just keep our relationships on a business kind of level. And that would be a kind of dismissive attachment style. If I see somebody with that attachment style, what I often think is a therapy is likely to help them, that helps them get in touch with their feelings, because they tend to keep them lower. So those sort of people, if there was a choice of therapies and there wasn't one that was particularly obvious, I think, well, I'd probably put them in a therapy that did more around feelings. So that might be a psychodynamic therapy, or it might be a cognitive analytic therapy, or it might be an IPT therapy. What I wouldn't go for with that sort of person necessarily was a CBT therapy, because they're good at thinking and their thoughts and working things out. That's very easy for them. What they're less good at is getting in touch with their feelings. So I'd go for that style. The other style that you tend to see in doctors is what I'd call a more preoccupied style, which is that doctors are really kind of in touch with their feelings. They feel their feelings very intensely, and they feel the feelings of others very intensely. Usually a clue to this is the doctor who comes to me and says, I've had a 30-year complaint, I've had a 30-year career and I've never had a complaint, because they're really good at reading their patients. They're really good at being emotionally in tune with their patients. Their patients love them. What they're good at is that emotional feeling. What they may not be so good at is the kind of the cognitive thinking and planning. They might kind of dive in emotionally with 2 feet, but be less good at kind of standing back and kind of being a bit more businesslike and observing. And for that kind of doctor, I might think they'll really like a psychodynamic therapy where they can express their feelings and talk emotionally, but actually they're really good at that anyway. Perhaps what they might really value is a cognitive therapy, which will encourage them to kind of step back and think, and kind of take some time. So I've become, I am interested in when people present to me and the choice of therapy isn't obvious, is what sort of person are they? And I often encourage people to go for a therapy style that doesn't play to their strengths. what one that is takes them into areas where they don't normally go. In that sense, I hope that makes sense. If not, it's not very long before it ends, so I'll be able to take questions on it. Okay. So how to choose a therapist if you're not going through an organisation that will give you advice on this is it is the Wild West out there for therapists. So therapists aren't like doctors. They don't have to be registered. Anyone can call themselves a therapist or a psychotherapist. So I'd certainly, you need to make sure they're registered. I've written a variety of registration organisations there. There may be others that I've missed. So BBC, British Psychoanalytic Council, that's one I'm registered with. UKCP is another good registering body for psychotherapists. A lot of your cognitive therapists will be registered with the BACP. BACP is another registering body for cognitive therapists and other therapists. UKCP similarly. ACAT is where your cognitive analytic therapists tend to get their registration. And IPT UK is where your IPT therapists tend to get their registration. If you go onto any of those websites, they tend to also have a find a therapist page. So you can put in where you live and they'll give you a registered therapist who's around. It doesn't guarantee they'll have availability though. So a key thing for therapy is, are they registered? And then I think the other key thing is, if you're lucky enough, is do you have anyone you know who's seen a therapist locally, and would they recommend them? Yeah. So like a restaurant, I would take a recommendation for a therapist above all else, really. But you may not have that opportunity. But it's always worth reaching out and thinking who might know. Certainly, if you've got any psychiatrist friend or psychotherapist friends, that they will know who's around in the region and who's good. And similar to a restaurant, what you will tend to do when you go and meet with a therapist for the first time is have an initial meeting. That's usually free. And then if you don't like, if you don't click, it doesn't feel right, don't go back, go to another therapist. Yeah, there's no commitment to that first thing. In a similar way that if you went to a restaurant, didn't feel right, you wouldn't go back. Yeah, that's okay. That's the same thing with a therapist. So that's how I would choose a therapist. Okay. And then that's what I've covered. So I'm very happy to take questions. And I hope that was okay.